Welcome back to Radiology Rewired. I'm your host, Dr. Vivek Singh. Today, we're going to be talking about the business of radiology and also the future workforce of radiologists and how that's becoming a paramount issue today. There's a lot of medical students that are still wary about doing radiology because of the threat of artificial intelligence. We'll talk about how that affects medical student interest, how that may propagate to the future and the radiology work shortage, and also how the current environment is really limiting the ability of radiologists to practice in their own capacity as individuals in private practices. So, we've got a couple articles to discuss today. The first article I wanted to talk about is from Forbes, titled Radiology's Reckoning: How AI, Private Equity, and a $2,500 wellness scans are unraveling the road to happiness. What does that acronym mean? What does ROAD mean? ROAD stands for radiology, ophthalmology, anesthesiology, and dermatology. They called this the road to happiness. And they're some of the most competitive specialties in medical school because of the pay, lifestyle, and just general job. So, used to be that you could always just get into these specialties, become a private practice partner in an ophthalmology clinic or dermatology clinic or even in radiology and really have your own autonomy and have a really successful career. Those days are essentially gone. There's very few true private practices in radiology and these other fields these days. They're being taken over by hospital systems and private equity firms that are trying to improve their revenues as much as possible. And that ends up being the bottom line in a lot of these cases. Naturally, these four fields have physicians that are burning out in corporate medicine as they continue to see more and more patients, read more and more scans, forever decreasing reimbursement. In that article, we also touched base about these $2,500 per scan private companies that are popping up. One of the premier companies that's doing this is called Prenuvo. Prenuvo made a lot of recent headlines because it was celebrity backed, celebrity endorsed. You see posts from Kim Kardashian talking about her $3,000 scan and how she feels so much safer that it was negative. These scans do provide a 2 to 3% detection rate of cancers, which sounds really great. But we have to think about the other side of the coin. It also increases stress and anxiety about findings that are typically benign and would just be left alone and patients can live with. And instead, patients are going home with this possible finding and dealing with the workup and the chaos that goes with potentially having some kind of serious diagnosis. This leads to additional workups, biopsies, needles being put in places that they shouldn't be, and overall increased mortality slash morbidity for the patient. So the question becomes, is this really moving the needle? Are we catching enough cancers to make it worth it? Or are we just worsening healthcare anxiety? The other problem that this presents is the disparity between populations who can afford the scan out of their pocket and populations who can't, the large majority of who can't. So you are increasing the healthcare disparity with these emergence of new AI firms that are looking for preventative disease. And it's something that we really have to struggle with to ensure that we're not doing more harm than good in these patients. So we'll talk about this with our interviewers today. We're going to discuss how these specialties have been affected and how healthcare is being commoditized on a more grand scale. All right, so we got two special guests for you guys today. Dr. Lakhani joining us from West Virginia University, who's a neuroradiologist fresh out of training, similar to me, has seen the integration of these AI tools in residency, fellowship, and then now as an attending, and is going to comment on some of the things that he's noticed in AI. We've also got Dr. Vivek Yedavalli coming in from Johns Hopkins University, who's the head of neuroradiology there, much more seasoned attending, who's going to give us his expert opinion on what he thinks is going on in AI and the future workforce for radiology. Thank you guys for joining me.
Thank you for having us.
Thank you for having us.
All right. So, starting out, first off, just tell me your experience. We have this article that we talked about. A resident had written it talking about his perception of AI, very similar to what my experience was. You know, you go in 2016, people telling you not to do radiology, you're not going to have a job. I think you probably heard similar things when you were in training. What was your experience like coming into radiology residency with the boom of AI going on?
So it's very interesting, Vivek, that you just mentioned about during our residency where people were saying, "Hey, your job, you no longer will have a job in radiology." 10 years down the lane. In fact, I got a message from my dad a month ago asking, "Hey, I'm just reading one article which is saying like, AI is taking over radiologists." I'm like, "Where did you hear that?" So it was some, newspaper like headlines in India, which basically say AI is revolutionizing how the healthcare is practiced, and radiologists are the prime target for it. Uh, but having said that, I feel like while AI can and most likely take over some of the cumbersome, repetitive tasks that we do in our day-to-day practice, it's not going to take away our jobs. We as radiologists, I think, do way more than just reviewing images. We integrate the findings that we see into a broader clinical context. You link it with labs to ever-changing clinical status of the patients, and most importantly, patients' wishes and their expectations. AI, while it can help us, find those subtle abnormalities to help us triage more efficiently, to do some of the tedious work for us, like measuring things, to estimating the volume of tumor or enhancing tissue. It doesn't have the ability to integrate those things into proper clinical context. So while it can help us, it cannot take away the responsibility that we have in patient care, or it can take away our clinical judgments. So coming back to the question that you had, in since residency, there was a big hype of AI. Yes, it is helping us. It's reshaping the way we used to practice radiology, but it's not going to take away our jobs. As you would have noticed, when we started, the even algorithms that we use in daily practice, like LVO detection, hemorrhage detection, how good they were when we started, right? So they were flagging things when they were normal. They were not catching things when they were abnormal. So LVO, positive LVO case would not be flagged. Normal case would be flagged as LVO positive, right? So we have seen that. And slowly they are getting better. But again, it's up to us, the human expertise that we bring, to convert the data that your AI algorithm is giving you into meaningful information, translating into care. So our jobs are there and will be there no matter what algorithm comes in, right? Because at the end, it's our human expertise that convert that data into the meaningful information that could be translated into patient care. And that's what my experience has been.
Yeah, absolutely. And I think that's what I've shared too. What about Vivek? What was your experience, coming up and training new radiologists and talking to medical students interested in the field? What was your experience?
Yeah, I mean, when I was coming up, I'm a little bit older than you guys, so AI was still very much a point of intrigue and interest with how it may impact radiology. Of course, I think a lot of this stems down it stems from the fact that a lot of the public perception may have misconceptions about exactly what we do as radiologists because we're not patient facing in most instances. And we do a lot more than just imaging interpretation. As Dr. Lakhani was saying, he made a number of excellent points about how our job as radiologists extends well beyond imaging interpretation alone. I mean, we like to think of ourselves as the doctor's doctor, and we are consultants for other physicians, and certainly play supportive roles in a multidisciplinary team, and that's what we take pride in. And that's not just from a clinical perspective, but also a research perspective as well, where a lot of these multidisciplinary collaborations with other clinicians can lead to a number of new discoveries that we use and subsequently incorporate into clinical practice. So a radiologist is definitely an important member of that entire team, and that's not going to change with AI. It will certainly reinvigorate a lot of what radiology does in many different instances, and we have to think of AI as a supportive tool rather than any sort of enemy or something that could potentially take over our job. AI is very much going to be good for radiology depending on how we use it, and ultimately, it comes down to radiologists who use and get familiar with AI will probably put radiologists who do not out of business. And that's what we need to think about. We need to embrace AI and incorporate it into our everyday workflow.
Yeah, and I think you guys touched on a couple good points. It's like when we were coming out or joining radiology residency, there was so much hype about it. And I think we've progressed from this hype cycle to a hybridization, right? Where they're acknowledging now, and even Jeffrey Hinton, who made those bold proclamations in 2016. If you look at that New York Times article, they're talking about how your AI radiologist, it's going to be a hybrid setup, and that radiologist isn't going anywhere. And they interview a lot of these top, minds in the field. And one of those people they talk to is Hinton, and he says, like, very explicitly at the end of the article, yeah, I was wrong. It's not going to change any. It's not going to change the way they practice. It is going to change their role in the hospital and how they're more integrators of data, integrators of, like you were saying, that clinical picture and putting everything into context, and most importantly, verifiers of the data. There's no one in the hospital that's going to look at these outputs and know what's going on except for us. And that's why I think it's so important to, press this upon medical students that if you guys are listening, you guys need to stay interested in radiology, because it's going to just continue to take off. We're busier than we've ever been. We have better jobs overall, like, and more opportunities. Everyone's hiring. So it's a great field to be in. And I think it's really sad to see some of these, like, outside perceptions dictate what medical students end up doing.
And those are great points, Vivek. And just to add to that as well, the onus is on us to change the perception of our profession and our field. We need to really educate the public about what we do and where we add value, and we add tremendous value to any multidisciplinary team, and that's absolutely crucial, especially for patients to know. And we need to do a better job in many ways of being able to market ourselves as consultant physicians that help add value to the larger team. So that's certainly important. One thing to also keep in mind is that we have seen, and I'm sure you guys feel this too at your institutions, exponentially growing volumes of imaging. So imaging is become a cornerstone of the entire workup, has been and continues to be, if not more so now than ever, where a lot of the multidisciplinary teams are dependent on imaging to be able to treat the patients. And this is where we have an opportunity to be able to play a major role within that, and also keep our profession going by making sure that we inject ourselves into a lot of these discussions, be present, for instance with multidisciplinary conferences, be present, go over the imaging, really own that aspect of the entire process, and that's going to be on us to be able to do it, and I'm very optimistic that we will be.
These are great point. I will also like to add, like for the New York Times article, it really depicts the reality of what AI would be and is in the current state, because they're two different things, right? Performing in a lab is not similar to being reliable in a clinical setting where, so let me rephrase this a little bit. So performance in a lab is different than reliability in clinical setting, especially when patients' life are on the line.
Yeah.
So while AI is a great technology, it will definitely help us in do our jobs better, but it'll be ultimately up to us on how we integrate the information that we get out of that algorithm and apply it into broader clinical context.
How are your guys' institutions handling new AI tools? Like, who is evaluating this? Who has the most say in whether you keep a product or not? I think it's a very nuanced question, and it's something that I think a lot of hospital systems are adapting to, but I'm curious about your guys' experience in your individual institutions.
So at our place, radiologists have the say in terms of what new software we want to try, and what our needs are. We go back to what we need, like the softwares that we use currently are like perfusion softwares, LVA detection, hemorrhage detection, fracture detection. Um, we also do PE detections. In mammo, we have computer aided assist CAD, I guess. I don't know, computer assisted
Assisted technology.
detection, I
Yeah, just
guess.
yeah,
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 right.
yeah.
CAD. And for lung nodules, we have one on X-ray, one on CT. Depending on where we see the most needs are in terms of triaging and helping us to read studies faster, that's how we go out and see which software fits in, and we validate, or I wouldn't say we validate. We look at the publications that has came out for that software and see on how much diverse data set it's either trained or validated on, so that we know if this will be a good fit for our workflow or not. And then work list prioritization is very, very interesting. When our lists are getting backed up for, weeks at a time, for outpatient studies, we do need softwares or algorithm that can flag studies and help us triage more efficiently.
Yeah, absolutely. Those are fantastic points. At my shop, we have a specific committee that's comprised of both physicians and non-physicians to be able to vet different products, so we get different perspectives. It's very important to not only have the radiologist perspective, but also other clinicians and non-radiologists as well. Particularly how it may affect techs. We have a national shortage of techs. We've had that for a while, so being able to also improve the workflow for our technologists, I think, has to be an important aspect of this. But it really ultimately comes down to what are our pain points with our workflow. And a lot of it comes down to workflow optimization, and being able to garner histories through searching through EMRs, and getting better indications so that our reads are of even higher quality. So that's certainly an important component. Another situation where I think AI can have tremendous benefit is with these outpatient studies, like growing lists, and they continue to grow exponentially each year. But a lot of those outpatient studies, some of them, albeit rare, will have acute findings. So we need to make sure that we have AI programs that's able to at least preliminarily assess these outpatient studies for acute findings and bring them to the top of the list, so that we can read these in a more expedited fashion and get these results to their providers and the patients themselves. So those are just a couple instances where I think AI especially can help address a lot of the workflow pain points that we typically have to deal with on an everyday basis.
Yeah, and those are great points about the outpatient stuff and how important triaging is because, for the lay people listening out there who don't know kind of what our workflow is, when we walk in to our shift, sometimes if you're covering the ER, you're just walking into like 10 CT heads that have been performed. They're all stat, everything's stat. Then you have like, all your other x-rays, all these other things that are going to have critical findings, and you have no idea really what's hidden in all of these little packets. And then on top of that, you have your non-urgent outpatient scans that you're trying to get to after you clear all your stat stuff. So it is super important to have something that's running in the background to triage these things. And they're talking about hemorrhage detectors. There are certain AIs now that will basically, if it detects possibly some kind of hemorrhage on one of those head CTs, it's going to flag it and bring it to the top of your list. So that way, if the scan was performed, let's say in the past hour, you could have had 10 CTs. It's completely normal. We cover multiple hospitals. They're scanning people all the time. So it's really important to be able to be like, okay, let me make sure I get to this one first and convey these critical findings because everyone in medicine is busy. The ER doctor who ordered, half the time it's not the ER doctor, it's the triage nurse who ordered it because someone's complaining of a headache and then they have subarachnoid hemorrhage and they're still in the waiting room. But the CT head is on your list. So having these kind of, algorithms that are going through, and even if they're not correct all the time, you understand the value because if they are correct, the value you gain in getting that patient treated and cared for is just, you can't put a value on that.
And just to add to that too, those are great points, Vivek. But also the fact that we treat these patients in a timely manner.
Yeah.
A lot of times, a lot of the issues and that we may address, root cause analyses that we may be a part of, are delays in care. And this is specifically where having AI programs can have immense value. And I think that's an important component of this entire process. But one thing I would really like to emphasize, though, and this is of course a pain point for us as radiologists as a whole, is the information that we get with our indications. It's very different from having to read a study that says rule out trauma, rule out stroke, rule out abnormality, versus having a study where because we're able to use AI to extract more information, and we have more data with the actual physical exam, and it says, left mid flank pain, left sensory motor deficit with aphasia. That gives us a lot more information to be able to get those findings in a more expedited fashion and improve the quality of our reads. So I think that is certainly a top priority that we should utilize these AI products for.
Totally agree with you, Vivek. You know, the most the if they only tell me it's left or right, I'm still happy. With the ED, sometimes they just say like, is it left side abnormal, right side abnormal? Then I know where to look for. You
Right.
know, by this time, I don't expect them to tell me if patient has aphasia, sensory motor deficit. As long as they just give me laterality, that's all I need to make my read.
I think it's so funny you guys bring that up. I have a like a social media page on TikTok where I do a lot of radiology education, and I just included and posted a couple of the indications that I've gotten before. You know, where it's like someone just typed in like ASDF for the indication, just like the home row keys, because they're like, I'm not even putting anything in there, and it's like I was just trying to show people like, hey, this is what we're working with, and I just plead to clinicians like, help me help you. You guys are looking for an answer. Please provide me the appropriate information so that I can help you out. Because the other thing you notice is like people are so busy down there in the ER and things like the patient will come in, they get seen, they order all this workup. There's no note, there's no history. The first time patients in the ER, I have no clinical history, no idea what's going on with the patient. You call down to the ER, can't get in touch. They're coding somebody, they're busy. I get it, you know, but yeah, as your point well taken is like if we either have more time to spend reviewing the chart ourselves, and one of our other guests brought up and was like, let's take it a step further. You have the AI, like you guys are mentioning, that goes in and pulls all that information out for you and gives you, you know, hey, this patient has this type of tumor. They've gotten radiation on this date and they've gotten, you know, chemotherapy and all these different things. These all affect our interpretation. You know, when you're looking at like a tumor treatment response and all that type of stuff, if you don't have that clinical history, if that patient was treated at an outside facility and the notes are somewhere buried in like the media tab, it's really hard for us to find that stuff, especially when you're trying to read this complicated scan and you see your list and it's just blowing up in the background. You're like, man, I got to move. And that's just the nature of the job. It's the reality of the job. And that's why a lot of people are getting burnt out. But if we can ameliorate that whole situation by bringing these things to the forefront, it's going to help our interpretation so much. We're going to be much more specific, have a much better answer for the clinicians of whether a disease has progressed or not. And then on top of that, it just saves us so much time of like the headache of trying to rip through notes and find like in this 30-page scan discharge summary, what did they do for the patient, you know?
Totally.
And that's right. Absolutely right. One thing that we have to realize is this is not knocking our fellow physicians at all. You know, this is in many ways trying to help our physician. Anytime the ED is busy, we're busy. Like we work in tandem together. You know, so that's an important point. We certainly understand all of the aspects that they have to deal with, and we sympathize with that. You know, we sympathize especially with our ED and trauma folks and other disciplines with everything that they do as patient facing specialties. But when we think about something like an indication, it really comes down to exactly what you said, Vivek. Garbage in, garbage out. The more information you give us, the higher quality the read will be, and the more likely we are to able to answer your question more definitively. So I think that's where we need to be able to help each other out in different disciplines, ultimately for the betterment of patient care.
The next generation of radiologists isn't being replaced by AI, they're being empowered by it. From advanced imaging analysis to seamless workflow integration, Rapid AI's clinically proven AI gives radiologists the insight to read smarter and work more efficiently while keeping clinical judgment front and center. Because the future of radiology isn't artificial, it's intelligent. Rapid AI, powering the next generation of radiologists. What are you guys saying to the medical students in your reading room who are interested in radiology but are tenuous about the takeover of AI or just replacement of radiologists? What are you guys telling them?
So if a medical student asks me if my job will be taken away by AI, I just say no, it's not going to be. And I try to explain and give context, like, the AI algorithms that we currently have, and ask them like, how often have you seen this to accurately predict the outcome? And it is good, but at the end, it's not 100% accurate, right? So again, like it comes back to like it's up to us to integrate the data that AI gives you into the clinical context and then draw meaningful information out of it to apply to clinical care. So your job will never be taken away because AI can, yes, detect abnormalities and stuff, but it's up to us how we analyze it, put it into perspective, and then draw next steps after getting that information. So we are not just detecting abnormalities, we are trying to figure out which ones are truly abnormalities and which ones matter, and what to do next with it, not just simply flagging like, hey, this is abnormal, this is normal, right? And also the other thing is, it's also important to still learn the basics of radiology, right? Because you need to know when AI gets it right, and more importantly, when it gets it wrong. So, what normal looks like. If you don't know that, how can you evaluate an AI algorithm, right? So it comes down to the fact that it's the human expertise that is going to translate the data that whatever algorithm is spitting out, to convert that into meaningful information to drive again patient care. So your job will never be taken away.
Yeah, I mean, if a medical student asks me that point, I simply just show them our list, and they see that it's 50 to 100 deep, and realize that that we're not
Yeah.
going anywhere. Is if anything, we need AI. We need to view AI instead of looking at it from an antagonistic perspective. We need to embrace it. We need to embrace it so that we have the autonomy to be able to implement it where we need it most. And I think that's the most important thing to be able to convey to our medical students, that no, AI is not going to take away the job; it's going to transform it, and the transformation is entirely up to us. So we have to own it. We have to learn as much about it as possible. I think it has to be an important component now of the medical school curriculum, and certainly so for our own training programs, so that our trainees get more exposure to AI and see where it can be utilized and optimize our workflow especially.
These are great point, Vivek. I'll just add one more thing to it. I feel like rather than medical students' fear of taking away jobs by I think we should be looking at missed opportunities if we don't adapt to the change that AI is offering. Because if we partner with AI rather than fighting with AI, there is a lot which we can achieve, and it will definitely reshape the way we practice radiology today, right? And we have seen that like happening since residency training. It's slowly like, algorithms are getting better. Even with PowerScribe, just having an, I don't know, can I say PowerScribe where it's
Yeah,
not allowed
yeah,
pointer? Okay.
say it,
Yeah.
yeah.
So like even if you look at the dictation softwares, they come up with smarter ways of generating impressions for me. So like, and this recently started, right? So I was like 2 months into being an attending, I'm so used to it that I can't go back and dictate my own impression because I just hit smart impression. It gives you, especially when it comes to lumbar spine,
Yeah.
if it's whole spine, I have gone level by level at each thing. I forgot like, oh, which one is severe, which one is moderate,
Right.
smart impression makes it really efficient for me. So things like that. So if we start adapting to the things, it just makes our life much easier. So like, would AI replace us? No, but you would be replaced if you don't use AI, I guess.
Right. And I think that was the big quote from like a couple of the articles, was that the radiologist who uses AI is going to replace the radiologist who doesn't. And that's like the general theme, is that you have to get used to this stuff.
Absolutely, and I would extend that to all clinicians. I mean, we're not the only ones that will have AI be transformative for the entire discipline. When we look at pathology, we look at surgical fields too, where it can improve precision of execution of the surgeries. AI is transforming every single discipline in some way, shape, or form. So it's a matter of learning about it as much as we can, and ultimately that quote certainly holds true. The clinician, the physician who adapts using AI will put the physician who doesn't use AI out of business. And that's where we as radiologists, having, I would argue, the most knowledge about AI, can really own that space and move it forward. And for optimization of not just radiology, but medicine as a whole.
Yeah. And I think that it brings up a great point. What's happened over the past 10 years or so, it used to be like you had to give these nuanced explanations to medical students about our field. And now it's like, hey, man, it applies to everything. Everybody's going to be using it. You think like, primary care is so safe because you're seeing patient. Well, what if, everyone's run through this AI algorithm and now you're reducing the number of patients you actually have to see. And the primary care doctor is only seeing the sickest patients and the APP is seeing these pre screened otherwise healthy patients, and it's a lot less liable because they've already been pre-screened by some technology. It's going to be pervasive, right? And I think that adds to the argument that, hey, we're in a prime position to really we've been part of this for 10 years now, and our jobs have just become more secure and more in demand. So it just goes to speak like how important we are in this role and integration. The other thing I bring up to them is it is so much more complex and nuanced than people give it credit for. Of like, yes, AI is like, we're hoping to bridge that gap where imaging volumes are skyrocketing, number of radiologists are just like this, staying stagnant. How do we bridge that gap? We're hoping AI helps. But even that explosion of imaging, I bring up the point of there are AI algorithms that are reconstructing every sequence in a MRI from your basic sequences, right? It used to take like 30 minutes, an hour to get your full sequences. And now they're showing technologies that you do one sequence and can reconstruct all the other images from that. So you don't think that's going to change how many MRIs we get in a day? They're already running 24/7. We're hardly keeping up with anything right now. What's going to happen when every MRI takes 5 minutes? And then you think about the screening population. There are new algorithms that are reducing the radiation dose from some of these screening tests. So you add that in, and everybody's getting screened because why not? They're not going to get cancer from the scan. Might as well try to detect it. The screening numbers go up. All of this stuff, the imaging volumes are just going to keep going up and up and up. And it's like, we don't have some new crop of radiologists, hanging out on the right, just waiting to get subbed in. They don't exist.
That's a very key point. And that's something that we need to keep in mind as a profession, that we need to actually train more folks now than ever, because these imaging volumes are going up at such a steep rate. I think there have been a couple articles that have come out that have shown that CTA head and neck utilization is now has skyrocketed upwards of 80% of what it was before. That's absolutely nuts. So being able to keep up with that, we need to be able to train more folks, and incorporating AI to deal with the imaging volumes is only going to be beneficial for us. So we really need to embrace this technology and see where it can address our inefficiencies in the everyday workflow.
Yeah, and that's a great point about CTA head necks. I mean, we're all neuroradiologists over here, so we see that. And for the lay people out there, a CTA head neck is a very long study to read sometimes because there is so much information. It is a CT, a lot of times non-contrast of the head, then they give the patient contrast, so you get all the vessels, then you get extra reconstructions of the maps, and the indications sometimes it's like 22-year-old with dizziness, no past medical history. Why are we going straight to a CTA head neck? But this is just the reality of radiology and medicine these days. And again, everybody's busy. Like you said, we're not putting anyone down for ordering that. And you do see some occasional findings on these things. But the fact that, these large scale studies are showing how much the utilization has increased when sometimes it's not indicated, but it really doesn't matter. I'm not going to go see the patient from the reading room. If I'm going to call down and be like, why do you need this? Well, all they have to say is, I need it. I want it and I'm worried about this. All right. Well, now I'm reading it, and that's just the nature of the game for our jobs right now.
And to sort of an extent, I think we are just becoming like physical examination
Yeah.
study
Yes.
for them, right? Anyone comes up with anything, just get the imaging because imaging has the answer to everything. So that also highlights the fact that previously where we were used to seeing more positive findings, the problem is every time residents now open a study, their inherent expectation is it's going to be a negative study
Yes.
because most of the studies, like 90% of the studies coming in from the ED are normals, right? So finding those 10% abnormality can get challenging because you are constantly thinking and you need to go fast, right? So that's where really AI can help us. If they are able to flag with high sensitivity, at least we'll pay attention to studies that needs our attention, and those who are normal, we can screen them much faster than what we could without use of AI.
And that assumption that imaging can answer every question, we know is not true. We know the strengths and weaknesses of these imaging modalities as imaging experts. And that's an area of opportunity and growth for us where we have the expertise to show them that, hey, the CT is not the best study for this, maybe get an MR. And that adds even more value for what we bring to the entire team as radiologists.
Yeah, and I think that, when you compound the fact that there are more and more non-physician providers being used, that also adds to the amount of imaging that you end up getting. I mean, it's just basic like, if they're having leg pain, get a leg x-ray is negative, get a CT. If the CT is negative, move on to the MRI. That shouldn't be the progression, but sometimes we do see that, and this adds to the volume, right?
Yeah, definitely. We've tried to address this, and this is a great collaboration we have with the ED at our Johns Hopkins Bayview site. We've collaborated closely with the ED folks for more judicious imaging use to minimize the redundancy. For instance, if you're worried about a fracture, you don't need an X-ray and a CT. So having that degree of redundancy and being able to address that is also an area where we could utilize AI and redundant imaging that can be especially problematic and expose our patients to unnecessary radiation, which is another component that we need to be cognizant of.
That's a very good point that Vivek just brought up. So it's also a different perspective about what our referring providers want, right? So ED or emergency department physician would want their patients to spend as less time as possible within the ED, right, within the emergent setting. So for them, getting an CT up front will save that time so that they can discharge the patient better and they can spend more time on patients who deserves more attention. So from a different perspective, that's what their feedbacks are when we try to, sit down together and discuss how to cut down on these imaging that we are doing. But that's again a good opportunity for us. More imaging is coming in. It's more business for us. Try to figure out how to best address them. Using AI or newer technologies will be amazing.
Yeah, and one more, like, I think big point that's always in the background with all these new algorithms and our role and stuff is who's going to take the liability? This AI software makes a mistake and lets you go home and says it's normal, and then it's reviewed later on and we find something like who's liable if something goes bad for that patient? It's certainly not going to be the software company.
Whichever software company takes the liability, I'll get it.
Yeah, exactly. That's going to be the number one key to adoption right there. So you guys have seen, I mean, obviously you're on the radiology side. How have you seen recently AI kind of explode out into the clinical setting in your hospitals? Have you guys seen like, you listed off a bunch of AI tools that we're not really using that much at my institution. And I think it's very variable. Some academic places are going to be using more and they're going to be early adopters of this technology. Have you guys seen it kind of ripple out into like the clinics and like the clinician and inpatient providers?
I have personally not seen other than the only software that I'm aware about is in pathology, I guess, when they
Mm.
try to do those automatic calculations for cell counts.
Okay.
Other than that, I have not seen AI or I'm not aware of if they're using anything else.
Gotcha.
Same with Hopkins as well. We haven't seen AI really pervade a lot of other specialties too. To that extent, fortunately, with and unfortunately, to some extent, this is our biggest boon and curse. Being at a major institution where we have a number of different hospitals within the entire enterprise, things move slowly, and that's certainly an aspect of it where we need to vet these products and also look at where these products would be most beneficial because each hospital within our entire enterprise may have different needs. So that entire process takes time. And I don't think we're going to necessarily see that perhaps for another 5 to 10 years, where it's really an important component of our everyday practice. We of course have used that with a lot of stroke platforms such as Rapid, where we're very well versed with that level of AI and incorporate it regularly. But in terms of other types of platforms, we haven't seen that yet.
There's one that I can recall that we use in terms of like integrating EMR for finding the correct patient population for a specific study. So we have like tinnitus clinic um, and aneurysm clinics that we are trying to like see patients separately, and those algorithms will pull patients from the EMR that comes as a flag for them. So, for example, if CTA head was done in one of the other hospitals that we cover, one of the community sites, we just say there is an aneurysm, dictate, but no trauma. patient is discharged, that does flag and drags the patient to that list of patients called clinic of aneurysms, So you would be seeing those patients. So the interventionalist would have access to it in case if they want to treat the patient. Same thing with uh, we are doing for billing purposes in terms of like for example general epilepsy code, and mesial temporal lobe epilepsy, or even more specific if you say hippocampal sclerosis, the billing code goes up, right? So the algorithm does flag those things which are more ambiguous, and if it needs more specific diagnostic codes, and it also links those patients to a specific list where the interventionalist who was interested in doing something with those patients, they will be able to see them on their list, and see them in clinic if they want to. But yeah, we are using that part.
What do you guys predict the workflow, the day will look like for a radiologist in 2035?
I guess the future radiologists will be working with AI, and again, not against it. I'm again repeating that sentence. It's not going to be against it, but it'll be collaborating with AI, where we'll have work list prioritizations. Where triaging is more efficient, where AI is finding subtle abnormalities that we may not be able to perceive on regular scans. It would also help reduce burnout by doing some of the repetitive tasks that you may not want to do, like measuring lesion volumes to, quantifying carotid stenosis. So all these cumbersome tasks that we have to do, AI would help us do it. And then we'll be like using whatever data we acquire from those AI algorithms we use, we'll be integrating them into clinical practice and drive patient care. And I can assume that the future radiologist is going to be doing more higher level tasks because his time will be more freed up from all the tedious tasks that we have to do, like measuring lesions and labeling spine, that AI would take over that part. So you're spending more time doing higher level clinical decision making tasks, and collaborating with the clinicians to guide patient care.
Yeah, and in 2035, I envision our lifts being 200 deep, but when we walk in, but we're not freaking out.
Yeah, that's a great answer. Yeah.
We have prelim reads on all of them, and they're measuring a lot of these seemingly the tedious tasks that we have to be meticulous with in general. So I think that could end up being a standard day, and those reports will have much better histories because of LLMs going through a bunch of EMRs and getting us more useful information. But that's what I envision an everyday work day will look like in 2035, and that only speaks to the point that we as radiologists will certainly be in demand now more than ever at that.
And also, Vivek, I'll add one more thing. Like they'll also dictate prelim reports for us that we just have to look at it, change it, in more standardized fashion. Just move on.
I think consensus, dream AI is this AI is basically functioning as a really good resident for me. Has come through the chart, has predictated the findings. The report is beautiful. It's a, decent impression that I might need to change, a few things on, but overall I agree with the interpretation, and a lot of the critical findings are maybe preliminarily conveyed, and I'm just that, academic attending signing a study off, I don't know if that might be down the road. So, with all this new AI integration, I think something that comes up is how is that going to bias the radiologist in the future? There was one article, I don't think it was in this episode, but we talked about it in a previous one that showed that when they've looked at, these new AI algorithms and young radiologists using it, like me and him versus you using it, they've found that the more experienced radiologists look at the AI and they are more productive with that, but that the younger radiologists are more likely to be fooled and agree with a false interpretation from the AI. Like just so for example, like aspect scoring, right? For those who don't know, it's like a way to determine how bad the stroke is. You're looking at very like changes in gray and dark. And it's a very finicky thing. If you ask 10 different radiologists, they might give you 10 different scores in the same range. But it is something that those kind of applications can be really standardized well with AI because it's basically measuring density at that point and comparing it to the other side. So I think they found that the younger radiologist is like, oh yeah, it's an AI measured it, do it pretty good. Whereas the older guy is a little bit more, vigorous and is going to scrutinize the output and really comb through the images still. What I worry about is that during training, we're going to start becoming so reliant on these AI tools that, oh, if it didn't catch it, it's not there. And we're going to lose that ability to really comb through the images and find subtle findings when they need to be seen. How do we go about ameliorating that for like the trainees and making sure that they finish with a good, fund of knowledge similar to what I think that we experienced in residency?
That's a very, very good point. We need to emphasize to our residents that, texture analysis is still the most important task because, again, you need to know how AI algorithm is picking those findings. And most importantly, when it does not, how would you troubleshoot it, right? If you don't know how abnormality or normal study looks like, how are you going to, uh, like properly um, vet the findings that the algorithm is putting out? Because again, AI, no matter how good it is, it's going to give you the data, but it's up to us to put it in a clinical context. Like for one particular patient, the same thing could be like, if it's an old infarct, it's still like gray white loss, but it's acute infarct. Depending on the history you can help, or depending on how it looks like. But maybe the algorithm may not be able to do that. So it again comes down to the fact that it's up to the operator who has that information, link it, look at it holistically in a patient's perspective, and then interpret those findings. So it becomes very, very crucial to teach our trainees, to how to pick up the things that AI is going to do for you. But if you don't know how to do it, it's going to be very difficult for you to see if the algorithm has done it correctly or it's incorrectly, right? And what I would always emphasize to my trainees is, uh, double down on the human aspects of radiology too. Talk with the clinicians, collaborate with them, try to figure out what they are asking from you, what they need. Also, like, respect patients, sort of their wishes and their expectations with what they are looking for in their care, because that is something, no matter how good an algorithm is, it's not going to do that for you, right? So focus on higher level clinical tasks too. At the same time, learn the basics of radiology because you will need it to evaluate any of the algorithms. And as you said, younger radiologists, because we are so used to seeing that in our training, that, oh yeah, software picked up stroke, sure, it'll be stroke, and just move on. No, you got to look at the images and use it as a second rater rather than using it as a primary person interpreting those images.
Yeah, I'm a little bit older than you guys, but I'm young at heart. So so I certainly have straddled both eras with looking at this. I think it really comes down to emphasizing the importance of learning the basics of radiology. We should always be able to rely on our knowledge independently of the AI platforms that we may use. And I think we need to make sure to drive home the point, especially with our trainees, to urge the resistance toward cognitive offloading. Cognitive offloading meaning that we're not doing the actual thinking and we're too reliant on the AI to determine what's going on. And we need to make sure that's a point of emphasis in all of our training programs. And lastly, also understand the strengths and weaknesses of AI. AI is by no means perfect. There are a lot of false positives, false negatives that it may call, and that can certainly impact patient care. So our knowledge of understanding both the strengths and weaknesses of not just the modality, but also the AI products, we almost have to think of it as another modality that we have to understand, will be crucial to our entire training program and what we bring in terms of value to the entire team.
Yeah, I think that's a great point. I mean, you bring up like how these are almost like new technologies that are being developed that we have to now interpret, right? Like if we look at some of the beginning AI tools, it could, just show you an image with the aneurysm, like the slice with the aneurysm there. It's not telling you where it is, not telling you how big it is or anything like that. Whereas now you look at some of the deep clinical AI models where these things are displayed on a 3D vessel map, like beautiful pictures. There's a volume measurement on the aneurysm. It is showing you the aneurysm morphology. And, in neuroradiology, we know, and, the neurointerventionists know that the morphology of the aneurysm is, as important sometimes, if not more important than the size, the location at times, because all it takes is one little wall to rupture in a weak point in an aneurysm. But the point is that these outputs are being displayed with all this data. And it's like, we have to be the ones to put that together and convey to, the neurosurgery team who might not be looking at these images specifically. Hey, this is like a new way we're detecting these things. And I'm worried about this patient because they have this little outpouching on their 2 millimeter aneurysm, which is crazy to me that that's probably coming down the road.
That's a very, very good point, Vivek. The other thing is also like the change in time. These algorithms, like Rapid's aneurysm software, it also gives you the surface area of the aneurysm and minuscule changes over time. Which normal, like if I review it, I may not be able to perceive it. So those are the things. The dynamic changes are quantifiable, and we can detect subtle changes. And then, as you said, getting this information will be tremendously helpful in identifying which ones to treat and which ones to follow.
Yeah, absolutely agree with those points. But I think it's important to still have a healthy skepticism of an AI output and see where it augments your impression and your synthesis of all of the information that's there. It's a wonderful adjunct tool to have at our disposal, and we certainly need to use it as such.
And you brought up a point about this kind of cognitive offloading, and anecdotally, we're not even there in clinical medicine. I know we talked a little bit how you guys don't see it in your institutions yet, but down the road from Epic, from all these big EHRs, there's all this AI going to be integrated where it's an auto scribe listening to your conversation with the patient and creating the note, creating the physical exam for you as you're talking out loud, and then even coming up with an assessment and plan. So that's down the road, and it's going to take a long time for it to get like widespread adoption and integration in these healthcare systems. But anecdotally, I talked to some of my IM friends who are like chief residents at their programs and see, medical students and what they're doing now. And these guys are coming into the note room and just pulling out like a dictation and talking into Chat GPT and just ripping off like everything they know about the patient, today's labs, all of this stuff, and just be like, write my note for me. Boom, send, copy, paste into the chart, walk out of the room. No thought given to any of the assessment and plan because it's so well organized by the chat GPT about like, oh, these are the next steps and make sure you check this. We'll check these lab values. It's like, this is already happening, and it's happening all over the place. People are becoming more and more reliant on technology like this. And I think you guys make great points where it's so important to understand the fundamentals still. And that's why these training programs, I think, need to find a way that we still go through this residency and learn the basics without becoming over reliant on this technology. Because, like you said, you have to you be able to scrutinize all of these outputs to see if they're real or not.
I do think we're getting to the point where we need to make sure that teaching AI is a fundamental aspect of our curriculum within residency and fellowship training. And that's certainly where we need to adapt and incorporate readily with our training programs.
Speaking of that, Vivek, so what we did at our program was, as I was seeing, like our dictation software lets us use Smart Impression. We disabled it for our trainees because they were getting really, really dependent on it. So we wanted to make sure that they use AI when needed. It's not like they get dependent on it. So while they are still allowed to use some of the like alveo detections, hemorrhage detection, PE detection softwares because it comes on packs, fine. But at least like try to at least develop your own impressions about things, because otherwise it'll be very difficult to do it if you don't have AI with you. Especially when it gets it wrong, how are you going to fix it if you don't know how to dictate it?
Right, absolutely. I mean, and I think that like that's ultimately the impression, which is kind of crazy because we have these AIs now that are doing it. But that's where the radiologist provides value. Like the most value is in your impression, your interpretation of this smorgasbord of findings. Like incidental finding number 11. Like what do we actually need to do? Do we have a diagnosis? Can we get a unifying diagnosis? And I worry about some of like these, and I know I've heard similar things from my friends in private practice that have the smart impression. They're like they use it all the time. It's great for spine level type stuff where you talk about severe here, moderate here. You don't want to comb through all your findings and try to do that, but at the same time, I think there's so much value in being like, what is like the central point I'm trying to convey from this study? What do I need to prioritize? And more importantly, is there something urgent enough here that I need to like make a big deal about? Because we are ultimately the gatekeepers on what's a big deal and what's not, and clinicians are going to respond to us freaking out about something. So we need to be able to rightfully freak out when we should freak out.
Absolutely. So coming back to you, as you said, like the perception about AI and training, how it may impact the way we are training in the future generations that are going to be trained as radiologists, right? I feel like this is a good opportunity because we'll free up a lot of space in our brains to focus on things that really matters, more integration, more clinical oriented decisions that we take. Now I don't have to remember Fleshner criteria. Do you have it? I guess open
Hey, yeah.
lung reds or bi-reds, or any of the measurements that I used to memorize, like 6 years ago. We don't have to because everything information is at fingertips. So that is going to change. AI is going to change some of that, but that's for good. We'll advance the field because we'll focus on things that would matter. And I think it's a good thing. Like as you said, there are two sides of the story. Like that's what I think.
But that's also an important point for where we need to be cautious. Because if we don't know certain criteria, for instance, in and out, then we're not going to be able to check it readily, and we're going to become even more reliant on it. So we need to be cautious about that, and also still go back to the basics and know a lot of this knowledge that'll be useful to be able to check the work that AI may be doing. And this segues into a point with residency training, especially, that I'm a little bit concerned about when it comes to taking call overnight. Of course, there's been a lot of discussion with how AI can certainly help with overnight reads, and a lot of our programs have residents on overnight. But at the same time, I do have some concerns that our residents may use it too much as a crutch, and not develop their own ability to make independent calls. And that's something that is a very fundamental aspect of our radiology training, being able to develop the confidence and acumen to make independent calls. And if we're teaching to our trainees that we should be relying, even if it's tacitly so, that we need to be cautious and cognizant of that in our training programs.
Yeah, and that's a great point about independent call for those listening. The way a lot of radiology programs do it, and and we've been shifting away from this because of just all of the metrics required by a hospital. An ER that doesn't have an attending radiologist finalizing reads overnight might get dinged in their metrics. But on the flip side, for radiology training, you want to go to somewhere that does independent call, meaning you as the resident are alone in the hospital overnight with maybe a couple other residents, and you are running the whole hospital. You're reading every single scan, and you're putting your impression and you're conveying findings to the clinical team, and they're making decisions, deciding if they're going to take this little kid to the operating room because you saw a little bit of fluid between a couple bowel loops and now that kid's abdomen is open. You have to make that decision as a R2, R3, your third year of residency. And yeah, you're clenching a little bit. You're scared. It is a nerve-wracking experience, especially when you're first starting out. But that's ultimately how radiologists, develop confidence. You come back the next morning. Some days I remember leaving call and I couldn't fall asleep. I'm just like refreshing the charts, seeing how the OR note looked for this 8-year-old I sent to the operating room. And then you find out, oh my God, he had a bowel injury. You just helped save this kid's life. And it's really rewarding. And that's how you gain your confidence as a radiologist. And to his point, that is already getting shifted away because so much of hospital metrics are gauged on the radiologists and and who's making these final reads, and these surgeons and neurointerventionalists, they want to know for sure before they go do something. So it's something that we've been shifting away in training, And there's more overnight attending radiologists that are signing reports right after you dictate it. But you can imagine how that affects training. You're no longer the chief decision maker, and you've always got this backup. So even if you're not sure, you can be like, "Oh, it's okay. I'll leave it up to the big dog. He'll take a look and just sign it off." And if there's something that needs to be changed, but that really impacts how well you are able to work in private practice when you do start your first job. You do not want, I always tell medical students, residencies, when picking a residency, you do not want your first independent read to be your first day in private practice. You want to be, in a training system that supports you, that has some liability coverage, where you can make mistakes and grow as a doctor. And to your point, I mean, I think the solution that you guys have about just, hey, turn it off, sorry, learn radiology the real way, and I don't know how feasible it's going to be because a lot of these things are so integrated into our workflow, and it's just tacked on images where you have it looking for PEs and it's flagging things for you. We have to figure out a way, if we want like the best quality radiologists to graduate, we have to find a way to taper some of these AI algorithms as they're learning, I think.
But just to add to this for the trainees who and students who are going to listen to this, you really want to approach it to the point of where when you're reading a study, you've got to think about it as your name at the end of that report. So take onus of it. Take onus of it as if you are in that scenario where you are the only reader. So it's important that have that mentality, develop it, and maintain it throughout training because you're going to be better off for it later on.
And also, like coming to your point where it may not be feasible for us to take away the snapshots that AI has flagged within the packs, right? But trainees should be focusing on the CT or whatever the raw images are before looking at the AI outputs, sort of like double checking what they're finding as opposed to, using it as their primary source of information.
Yeah, and I mean, I think that's a good point too, because on the flip side, there's a lot to be gained by using AI to train people, right? Like if, the way that a radiologist trains or a resident trains is, you put your findings, let's say it's daytime and you're not alone and your attending is sitting right next to you. You say what you thought on the report, you dictate a report, and then you'll go over with your attending and they'll give you the ground truth, like the true what's going on, change your report accordingly. So if you do have like use cases that this AI is correct on their interpretation and stuff, it functions as another source for residents to, take the case unknown and then check what the AI said and see how they compared to the ground truth. And I think if you're utilizing it in that way, then yeah, there's a lot to be gained, and you can get much higher volumes and much better ground truth, and pick up on good practices. But I think it's up to the academic leadership and the residency directors to find a way to optimize AI to better train the radiology residents, and also make sure they're not getting biased when they finish. Trusted by leading academic centers and backed by more than 700 peer-reviewed studies, Rapid AI is built on a foundation of clinical validation and scientific excellence. From the reading room to real-world care, Rapid AI's solution enhance accuracy, streamline workflow, and strengthen confidence in every decision. Rapid AI, where human insight meets intelligent innovation. Learn more at rapidai.com. So I was going to ask you guys both about another factor that comes into play in terms of corporatization in radiology. It's a big thing, and we touch on it a little bit in some other episodes, but I wanted to get your guys' perspective because you're just out of training. You've seen job market the way it is. You probably have problems recruiting these days because the market is so wild. How has like the private equity and the kind of the commoditization of radiology changed in your guys' perspective, and what do you see moving forward?
All right, Vivek, do you want to try first?
Could you repeat that question one more time? It was going in and
Oh,
out.
sorry. I was asking about your thoughts on, private equity in radiology and the corporatization of radiology, and how things have been trending. And for the lay people, there's used to be a lot of robust private practices where the radiologist paired up with a few other radiologists. They own the imaging center. They are owners in the practice and have a lot of say. And we've moved from that to a lot of these private equity firms and bigger hospital systems that are buying up these private practices. The partners get this huge payout and retire. And then the young guys that just joined the group are now hospital employees or corporate employees and essentially feel like a cog in the wheel. When we talk about radiology burnout and what's contributing to that, yeah, it is a low volume of studies, but it's also having no autonomy and no real value in what you feel like you're doing every day because you're just churning and burning. So, how do you guys think, like, what was your perspective going and seeing all this, as an academic radiologist, and like, how do you see this stuff evolving in the future? Do you think this is going to be a trend that continues where we don't have any more private practice? Like, what happens to the field?
It's a great question, and it's an important point that we need to think about in general. We're not the first field to go through this. If you look at emergency medicine, that has been there have been large conglomerates that have taken over entire states. For instance, and other disciplines have had similar scenarios. We're seeing that now within radiology, and I think while it improves efficiency, for instance, it also comes with the downside of further commoditizing the field. So I think it's important to keep that in mind, and finding that balance is going to be challenging as we move forward as a field, so that we can have we don't just have this what I call poncho method, one size fits all for everything. When we're treating different demographics even within our own enterprises, and we want to make sure that we account for that rather than having these large conglomerates that may be serving vast regions and not able to actually treat the local communities and the nuances of each community to the best of their abilities.
I think the good side of that can be, providing subspecialty care to those patient population, right? Because smaller groups of practices may not have that capability to provide subspecialty reads to them. Like corporatization for them may be beneficial, in that perspective, that you will have a CAQ certified neuroradiologist or somebody who is a body imaging trained person reading the body imaging, as opposed to a general radiologist or a neuroradiologist reading an MSK-MR, which
Yeah,
may not
we
be
don't
as
like
good
that.
as MSK-MR, right? So that's the good part about the corporatization. That's what I would say.
Yeah, that's a great point. And to add to that as well, I think it improves access for rural hospitals and just rural care in general, where of course a lot of outcomes are way worse than what we see with larger urban and suburban centers. So that's certainly an area where having that subspecialization, this entire process is so important to being able to treat those folks that who would not have otherwise gotten
And
care.
I can speak for our setup, like, by taking over imaging of certain smaller hospitals within the entire state. We do have some rural parts. So their imaging protocol improved. They are using cutting edge AI technologies to find LVOs, to hemorrhage detections, and able to do perfusion. Where they were initially struggling even to do a normal CTA exam, right? So that's the good part about it, that you would have skills and training for their workforce to perform some of the technologies or exams that they would not be able to do without that.
Yeah. So I have two radiologists here. I got to ask you guys opinions on these new startups regarding preventative scanning. For example, one of the bigger ones, Pernuvo, it's a full body MRI. Got to pay out of pocket $2,500 to $5,000. Lots of celebrities doing it. What are you guys' thoughts on this? And how do you feel about it?
All right, Vivek, your question.
I think we need to approach that very cautiously, because as we talked about, our lists are growing exponentially. We're not training enough folks yearly to be able to keep up with these growing lists. So my question to anyone who's getting that is, how long do you want to wait for that read? It's going to take a while. And who do you want to read the whole thing? There's a reason why each one of these body parts are split up and we have specialization within radiology. So that one entire full body scan may require 4 to 5 radiologists reading the entire thing, and that could take perhaps days to even weeks. So I think ultimately it comes down to the fact that there's a misperception that we just do the imaging and then eventually it'll get read, and that's problematic for us as a field because we're trying to deal with these growing volumes, and that's only going to add to that. So it really comes down to that question: how quickly do you want that read?
And just a heads up, these firms are, I think, from my understanding, I've seen them, hiring radiologists, but I'm pretty sure they're pre-screened by the AI, and then you have a radiologist just approving or denying this, and they claim a 2%, detection of malignancies otherwise not known. But I always worry about like downstream effects, right? You're getting incidentalomas, as we say, you're getting extra workup, you get fear and anxiety for something that's probably a nothing burger. All these things are factors that you have to consider. What were you going to
So,
say?
so absolutely, Vivek. So that's what I was going to ask you. Like, sure, they are detecting 2% cancer, but what's the clinical utility? Did it affect the
Right.
survival, or it's just
Exactly.
they detected thyroid nodule? Oh,
Yeah,
yeah, that could be cancer.
exactly.
Could
Yeah.
be cancer.
Yeah.
Or so my take on any screening exam is, the reason why we are successful in implementing screening programs like lung cancer screening trials, right, or lung cancer screening that we do, or prostate MRs that they do for screening with positive PSAs, to other surveillance imaging. There's some data behind it. You're targeting the population who is at risk, like normal healthy person walking in, you start scanning them.
Yeah.
It's just
Yeah.
it's
Yeah.
just no brainer. Same thing with coronary artery disease. People have just started opening their own scanners as screening. It's not just here. Even in India, they had this. Like where, oh, do you want a screening coronary artery disease? I'm like, okay, so 35-year-old person, completely healthy. Why would you need a coronary artery? Oh, it gives you calcium score. I'm like, okay, what do you do with it? Oh, it gives you a risk. Okay, but what's the next step? Like, what are you going to do if you have calcium? We don't have answers to that. So why you detect something that doesn't matter, or have a specific, or let me step back and say, like, these screening exams are great, but it's useful in certain population where it's shown to be effective and you find something clinically meaningful. Like healthy individuals screening with MR, it's useless.
Yeah. Yeah, that's kind of my take. It seems like somewhat of a cash grab these days for sure.
It's good money if they pay me. I'll read it.
Yeah, that's right. Yeah, yeah. I've definitely talked to people who are interested.
Concierge MRs
Yeah, exactly, exactly.
with CTs too, especially if that's a part of it. Just like we have our lung cancer screening CTs, those are very low dose. We need to also be keep in mind these cumulative radiation doses that they cause the cancer that we're screening for. So so we got to keep that in mind.
I think they have shown some studies in mammography in particular that sometimes these, the annual mammograms, even though we kind of recommend that as a society in the ACR, there's mixed reviews on whether we're doing more harm than good by radiating the breast tissue so much and maybe causing more cancers than we're actually finding. So I think it's a great point about, selective screening, right? Selective screening that you're going to have the highest benefit from, highest, increase in longevity from those screenings, and that's really what should be targeting. Dr. Yedavalli, this is a question for you because he's just like me. We're fresh out, so we don't have these eye-opening experiences like you've had. So I ask these questions to some of the guests every episode. What is one experience in your life or your career so far that has essentially rewired the way you thought about healthcare and medicine and the way you practice?
That's a that's a great question. That's rewired the way I think about healthcare in general. You're saying.
Yeah, some kind of like either eureka moment or something like that that really opened your eyes to like, oh wow, this is how it is.
I would say that really a lot of it comes down to how we are implementing AI. I mean, as crazy as that sounds, it's really seeing where we are as a field relative to what people think we will be. We have a long way to go. We have a long way to go. I think that's a realization in general that a lot of radiologists may have as they're going through it. Because there was a, when I was applying a residency, there wasn't as much of a fear of AI taking over yet. So I started to experience that later in training and when I became an attending. But the realization over time, and it's been more gradual rather than a one single eureka moment, is that we're going to be around. Our jobs are going to change, but we're going to be around, but we need to be adaptable. And that is the main thing that we need to take away from viewing AI in general as a tool that can augment and optimize what we do rather than viewing it with suspicion and being antagonistic with the entire process. Embrace AI and be able to utilize it in your everyday practice because it's going to make you better as long as you allow it to, and as long as you continue to be malleable and adaptable with the entire process and are willing to learn. As we always talk about, we're lifelong learners. We like to say that line often, but when it comes to AI, that has to be true. For our trainees and students who are listening to us, just keep in mind that even though we're not seeing patients, we are an important part of the entire uh, team that's making decisions that impact patient care. So as I like to say, we may not be seeing patients, we see through them.
That's a good one.
Yeah, that's good.
I'll just add one more thing to it. Whatever tools and technology we have at our disposals, it at the end, it's the patient care. That's what we should be focused on, to make it better for them. It's about delivering the best care every time for every patient.
And that's ultimately just the unchanging mission for our jobs, right? And on that note, thank you guys both so much. I think that's a great summary of the points that I wanted to convey to the trainees, medical students, and about the future task force in radiology. You got to learn to adapt and just get used to these things being there because it's only going to grow from here. Thank you guys both for joining me. This has been fantastic. I think it's going to be really helpful for all the students listening out there.
Thank you so much for having me.
Thank you for having us. Appreciate it.
So in this episode, we discussed the business of radiology and how that environment has changed over the past few years with private equity and hospital takeovers of private practices, not only in radiology, but in other really lifestyle-oriented fields, and how that is changing the future of the workforce. We also discussed the upcoming medical students and what they should be focusing on to become a radiologist, making sure that they stick to doing procedures and making sure that residency programs are integrating AI technology to ensure that the young radiologist isn't biased by the new AI technologies that are coming out. If you like this stuff, please like, share, comment, and provide some feedback to me about what you guys want to learn about next. And stay tuned for the next episode where we delve into more about the future of AI and what kind of applications we're going to be seeing.